After 10,000 open-heart surgeries, I've seen things that changed everything I thought I knew about blood pressure. I've stood over patients who did everything right, they cut the salt, took the medication, followed every single guideline, and still ended up on my operating table. That pattern haunted me, and when I finally dug into the research, what I found shocked me. The medical community has been focusing on the wrong target for decades. Salt is not the primary driver of high blood pressure in most people over 60, not even close. And the real cause, the one sitting quietly behind the scenes in the majority of my patients, is something most doctors never even test for. I'm Dr. Sarah Mitchell, and this channel exists to bring you the most current evidence-based health research specifically designed for adults over 60. If you haven't subscribed yet, please do that now. Every week, I publish videos that could genuinely change your health outcomes, and you don't want to miss what's coming. Now, let's get into this, because what I'm about to share could explain why your blood pressure medication isn't working as well as it should. The real cause of high blood pressure in the majority of people over 60 is something called endothelial dysfunction. Say that with me. Endothelial. The endothelium is the inner lining of your blood vessels. A layer of cells so thin that if you stretched it out flat, it would cover 6 tennis courts. This lining does one job above all others. It produces a molecule called nitric oxide. Nitric oxide is what tells your blood vessels to relax and widen. When your endothelium is healthy, nitric oxide flows freely, your vessels expand, and your blood moves through with ease. When the endothelium is damaged, and in most adults over 60, it is damaged. Nitric oxide production drops, your vessels tighten, resistance builds, your heart pumps harder. That's high blood pressure. This is not a fringe theory. A landmark study published in the Journal of the American Heart Association found that endothelial dysfunction was present in over 78% of adults with treatment-resistant hypertension. Not borderline dysfunction, clinically significant damage. And yet the standard treatment protocol doesn't address the endothelium at all. It addresses the symptom, the pressure, without touching the root cause of why the pressure got high in the first place. Now, I want to ask you something. Before you keep watching, take 30 seconds and think about this question. Do you know your nitric oxide status? Most people don't even know that's something that can be measured. Comment below and let me know. Have you ever had a doctor mention nitric oxide to you? I'd genuinely like to know what you've been told, because the gap between what research shows and what patients actually hear is wider than most people realize. So, what damages the endothelium in the first place? This is where the story gets interesting. There are 3 primary drivers, and one of them is responsible for more cases of treatment-resistant blood pressure than any other single factor. The first driver is chronic low-grade inflammation. When your body is in a persistent state of low-level inflammation, the kind that doesn't cause obvious pain or fever but silently damages tissue, the endothelium is one of the first casualties. Inflammatory molecules called cytokines directly attack that delicate inner lining, reducing to produce nitric oxide. Research published in Hypertension in 2022 found that adults with the highest levels of C-reactive protein, a standard marker of inflammation, were 3 times more likely to have uncontrolled blood pressure despite being on medication. The second driver is insulin resistance. This one surprises people. They associate insulin with diabetes, not with blood pressure. But here's what actually happens inside your body. When your cells stop responding properly to insulin, which happens gradually and silently, often over a decade, your pancreas compensates by pumping out more insulin. That excess insulin in your bloodstream directly stimulates the kidneys to retain sodium and water, increasing blood volume. It activates the sympathetic nervous system, which constricts blood vessels, and it accelerates endothelial damage at every level. A 2023 study from Johns Hopkins found that adults with insulin resistance had a 44% higher risk of developing hypertension within 5 years, independent of their weight, diet, or sodium intake. 44%. And insulin resistance affects an estimated 88 million American adults, most of whom have no idea. But here's what shocked me most when I started reviewing the research in depth. Let me tell you about a patient named Harold. Harold was 71 years old when he came to see me. He'd been on 3 different blood pressure medications for 6 years. His pressure was still running 150/90 most mornings. His doctor had told him to cut back on salt, and he'd become almost obsessive about it. He wouldn't eat anything from a restaurant, refused to add salt to food, even bought low-sodium bread. His blood pressure didn't budge. What Harold had never been told, what no one had tested him for, was severe insulin resistance. His fasting insulin was 32. The upper limit of normal is around 10. His endothelium was inflamed and damaged, producing almost no nitric oxide. We addressed the root cause. Within 14 weeks, Harold's blood pressure was 128/78 on just one medication. Harold's story is not unusual. It's the rule, not the exception in my patient population. Now, the third driver of endothelial dysfunction is chronic magnesium deficiency. Magnesium is the fourth most abundant mineral in your body and directly required for nitric oxide synthesis. Without adequate magnesium, the enzyme that produces nitric oxide, ENOS, cannot function properly. The cells can't relax, the vessels stay tight. A meta-analysis published in the European Journal of Clinical Nutrition reviewed 34 randomized controlled trials and found that magnesium supplementation produced a statistically significant reduction in both systolic and diastolic blood pressure. The effect was modest in some studies and quite substantial in others, but the key finding was this: the benefit was greatest in people who were deficient to begin with. And surveys consistently show that between 50 and 60% of adults over 60 in the United States are not meeting recommended magnesium intake from food alone. Here's the critical piece that most people miss. These three drivers, inflammation, insulin resistance, and magnesium deficiency, don't usually appear alone. They travel together. They reinforce each other. Insulin resistance drives inflammation. Inflammation worsens insulin sensitivity. Magnesium deficiency accelerates both. Standard blood pressure treatment addresses none of them. This matters enormously because standard treatment gives you a false sense of security. Your pill brings the number down on paper, but the underlying damage continues. The endothelium keeps deteriorating. The inflammation keeps building. Which is why so many people who have controlled blood pressure on paper still end up with heart disease, stroke, and kidney failure at the same rates as people whose pressure was never controlled. Think about the patients I've operated on. Many of them had blood pressure that looked fine on their chart for years. The chemistry underneath told a completely different story. Let me give you the second piece of evidence that changed my thinking. A woman named Dorothy came to me at 68 after her third cardiovascular event in 4 years. Her blood pressure had been medicated and seemingly stable the entire time. When we ran a complete metabolic panel, not just standard cholesterol and glucose, but fasting insulin, homocysteine, C-reactive protein, and magnesium, every single marker was abnormal. Not her sodium, not her blood pressure number. The underlying machinery was broken, and nobody had looked at it. Dorothy's case is why I'm making this video, because if you are over 60 and you have high blood pressure, or if someone in your family does, the question you need to be asking your doctor is not just, what is my number today? The question is, what is driving my pressure up at the cellular level, and are we addressing the cause or just the symptom? Now, let me give you something concrete and actionable, because research without a plan is just interesting conversation. Before I do, I want to share one more finding that I think is genuinely underappreciated. A study from the NIH published in 2021 followed over 4,000 adults with hypertension for 8 years. They found that the group that addressed insulin resistance through dietary changes had a 31% reduction in major cardiovascular events compared to the medication-only group, even when both groups had similar blood pressure readings on paper. Same number on the monitor. Dramatically different outcomes in real life. That finding should be front-page news for every adult over 60. Instead, almost nobody knows about it. Here is exactly what you should be doing if you have high blood pressure or are at risk for it. First, ask your doctor to test your fasting insulin level at your next visit, not just fasting glucose. Fasting insulin. The test costs almost nothing and is not part of standard blood work, which is why most people have never had it done. Your fasting insulin should ideally be below 10. If it's above 15, you have significant insulin resistance regardless of what your blood sugar looks like. Second, add magnesium glycinate to your daily routine. Glycinate is the form that is best absorbed and least likely to cause digestive upset. The research-supported dose for blood pressure benefit is 300 to 400 milliliters per day, taken with dinner. You can find magnesium glycinate at any CVS, Walgreens, or Costco, or order it on Amazon. Look for a product that says magnesium glycinate, not magnesium oxide, which is the cheap form that absorbs poorly. And check for either a USP-verified seal or a third-party tested label on the bottle. Give it at least 8 to 12 weeks before assessing whether it's helping. Benefits are cumulative. Third, reduce the foods that drive insulin resistance most aggressively. These are not the foods you've been warned about. They're refined carbohydrates, white bread, white rice, pasta, packaged cereals, crackers, and anything made with enriched flour. These foods spike blood glucose rapidly, trigger the insulin surge that damages blood vessels, and contribute directly to the cycle of inflammation that drives blood pressure up. You don't have to eliminate them overnight, but reducing them meaningfully, particularly at breakfast and as evening snacks, will have a measurable effect on your fasting insulin within 6 to 8 weeks. Fourth, consider increasing your dietary potassium. This is the mineral that counteracts the blood pressure effects of sodium far more powerfully than sodium restriction alone. The DASH diet studies, which are among the most replicated in cardiovascular research, showed that increasing potassium from food produced a larger blood pressure reduction than reducing sodium intake by the same margin. Avocado, cooked spinach, baked potato with the skin, white beans, and salmon are all excellent sources. Aim for foods rich in potassium at 2 meals per day. Fifth, get your C-reactive protein tested. This simple, inexpensive blood test measures systemic inflammation and gives you a direct window into endothelial stress. A CRP above 2 mg per liter is a meaningful warning sign. If yours is elevated, that conversation with your doctor about underlying inflammation is not optional, and it's urgent. Please do not make any changes to your current blood pressure medications without your doctor's direct guidance. These recommendations work alongside medical treatment, not as a replacement for it. If you are on blood pressure medication, blood thinners, or any cardiac medications, you need to discuss magnesium supplementation specifically with your prescribing physician, as it can interact with certain classes of drugs. And if your blood pressure is severely elevated, consistently above 160/100, please prioritize getting medical attention before making any dietary changes. Here's what I want you to take away from everything you just heard. High blood pressure is not just a plumbing problem, it is a chemistry problem. The numbers on your monitor are the end result of years of cellular damage happening quietly in your blood vessels. Damage driven by inflammation, insulin resistance, and nutrient deficiency that standard care almost never addresses directly. Treating the number without fixing the chemistry is like turning off the smoke alarm without putting out the fire. You now know more about your own cardiovascular system than most adults in their doctor's waiting room. Use that knowledge. Now, I'd love to hear from you in the comments. Comment your current systolic number, just the top number from your last blood pressure reading, and whether you've ever had your fasting insulin tested. This gives me a picture of what seniors watching this channel are actually dealing with, and it helps me plan the most useful content for you going forward. You can also comment testing this if you plan to ask for the fasting insulin test at your next appointment, or comment sharing if someone in your life needs to hear this information. If you haven't subscribed yet, please do it now. Next week, I'm covering the 5 warning signs that your blood pressure medication is damaging your kidneys. Signs that are often misattributed to aging and almost universally overlooked. You don't want to miss that one. I'm Dr. Sarah Mitchell. Take care of yourself, ask better questions, and I'll see you next week.